Hi, it's Dr. Centeno, and thanks for joining us today live on You've Got the Power. Today, we're going to go over an interesting topic, which is the transverse ligament. I've talked about it a number of different times, but the question is, how do we know if there's a problem with it? Now, that's a key kind of craniocervical instability. In the grading schema I developed, it's a type 2A, where the dens is coming apart from the atlas, mostly in flexion. So how do we know it's a problem? What research is that based on? What would the symptoms be like if you had that problem? And how is it different than other kinds of craniocervical instability? So we're going to dive into all of that today. Anybody can ask a question. I'll start with just maybe a 5 to 10 minute didactic portion. Then we'll get into questions. Questions can be about that topic, can be about any topic. And let me go ahead and cue that up here. So again, we're talking about the transverse ligament today if you're just joining us. And I'll share my screen. And then we will get started. Again, talking about the transverse ligament. I'll go through this and then take questions. So the ADI and the transverse ligament, what's normal, abnormal? What are the symptoms of this kind of problem? So you've probably heard a lot about some of these ligaments. We have the hold on a second, guys. I'm going to fix this. I just need to save it as another name. It's only doing read-only right now, so hold on a quick second. Apologize for the delay. Once that saves, we should be good to go. Okay, let's go back to where we were. So again, talking about the transverse ligament, you've probably heard about lots of these ligaments. We've got the alar ligament, which comes up from C2 to the skull. We've got the accessory ligament that lives on the sides here and jacks into a portion of the alar ligament. And then, and this is from the front to the left, but if we look top down, we're going to see that this is the atlas here, or C1. C2 is shown, and that transverse ligament is acting like a seat belt for the dens. And so the C2 here is the dens, also called the dens. So it keeps that dens up against C1, or the atlas, and that's its primary function. Now, I've drawn some things here very simply and oversimplified it to kind of show you what all of this looks like. If we go into the body, it tends to look more like this, although lots of things are missing here. But you can see here that this is the dens of C2. This is C1, or the atlas, C2 down there. And then the yellow structure here is that transverse ligament. So you can see how it's holding the dens to the atlas. And here on this side, you can see it in a little better view. Here we're looking from the back, and we've taken a lot of things out to be able to even see where that transverse ligament lives. So the spinal cord's missing here, the skull is missing, obviously. Many of the ligaments are missing so that we can see through all of that stuff. Now, the way it really looks is this cruciate ligament. Cruciate in Latin means cross. And so you can see that cross-shaped structure. And it's really the lateral bands of that cross that we call the transverse ligament. So there's a little bit more to it than just a ligament that acts as a seatbelt for the dens. You've got a top part and a bottom part, which make up the cruciate ligament. So you've got really fibers going in two directions, one this direction, the other that direction, shaped like a cross. As far as instability goes, what happens if we damage that transverse ligament, and that's a type 2A, which we've talked about before. And what that means is, all things being equal, when the person goes into flexion here, there are lax ligaments in the back, and one of those would be the transverse ligament. There's also ligaments up top that we've talked about, smaller. There's also a tectorial membrane here. But the big one that allows this ADI to open, ADI, adlenodental interspace, is that transverse ligament. So as the person bends forward, the atlas shifts forward. Now, remember, the atlas and the skull are kind of connected. So it's really the atlas and the skull that are coming forward because they generally move as one unit unless something's affecting the stability at 0, 1. So what kind of symptoms would this kind of thing cause? Well, CCI symptoms for sure, but that get worse in flexion. That's sort of the biggest pathognomonic thing that makes me, as an expert in craniocervical instability, think that there may be a transverse ligament issue, that almost all the patient's symptoms are when they're looking down or their head goes forward. So that's where the head and atlas, the atlas and the head slip forward on the dens. So, and that's when you look down. So normal versus abnormal measurements. How would you tell if you had this, right? There's one thing to say, well, my CCI symptoms, they tend to get worse when I look down. It's another thing to say, well, there's a problem here with the transverse ligament. Now, we could take a picture of the transverse ligament, but the problem is we really won't know how it functions until we look at this adlenodental interspace. So previously, 3 millimeters in men and 2.5 millimeters in women are the numbers that were used. But that goes back to 1960. And if we look for a more recent analysis, there was one about 10 years ago that kind of really changed all of this. What the newer study showed was that if you were older, these tolerances were much, much smaller. So this is the newer study. It was published about 10 years ago. We're now going from 1916 to 2013. And a lot of people in this study, including normal controls. Now, this is just a neutral seated x-ray. They didn't do flexion extension like they would do in a DMX or an upright MRI. And uniquely, they actually measured that ADI in 3 different places. So I'm going to draw it out for you here. This is the atlas, and this is the dens. And the distance between those two, they took the distance at 3 different spots and averaged that. Because sometimes you'll see this open up like a V. That's the most common thing you see. Sometimes it opens up symmetrically. Every once in a while you can see it go like this, but pretty unusual. But I think what they're trying to accommodate here is that when it opens like a V, you're getting points for that, if you will, on this ADI measurement. So they took these 3 measurements at 3 different locations and they averaged them. Now, here was the super interesting thing that if you're young, under 31 years of age, then 2.5 millimeters is about right for the maximum measurement there. But look what happens as you get older. So by the time you hit your 60s, if you've got really anything more than 1 millimeter, it's abnormal in that ADI. And they believe that they postulated that the reason for this was that there is a joint there and a bursa. And over time, that the joint cartilage can get worn down as people age. And so that space decreases in size. But interesting to know that if you're older, the tolerances there for being abnormal are much, much less than if you are under 30 years of age or so. So in conclusion, a normal ADI is much smaller in the elderly, at or equal to 1 millimeters. Actually, Yeah, that's right, a normal ADI. It's much larger in the young. So there now we're at a tolerance of about 2.5 millimeters. So if it's 2 millimeters, if you're young, it's probably normal. But if it's 2 millimeters and you're old, it's abnormal. And the difference is likely due to that lost cartilage in that joint there. So this is a critical thing, right? We're constantly, and it's something I constantly struggle with, is trying to be honest with patients. Are we seeing motion that's normal for the patient, or is it really abnormal and likely to be causing symptoms? And if you've done a telemedicine with me, you know that I go through that whole speech. Either I think it's highly likely that what we're seeing on this imaging is causing your symptoms, or I've got less confidence that what we're seeing on the imaging is causing your symptoms. Or you may have this or that, but it's really kind of within the realm of normal movement. Okay, well, let me stop sharing here and going to go to see if we have any questions. Looks like we got a bunch. So we'll get started answering those. It's been advanced by John Gardner. Hi, doctor. When you treat a person for cervical cranial syndrome, where do you inject PRP? Does it go all in one spot or all over the neck and back? You know, John, that's determined by a hands-on physical exam. So, for example, in one patient, it might go into the right 0-1, 1-2, 2-3 facet joint. We might do the posterior ligaments, maybe the right greater occipital nerve. The next patient comes in, exam is completely different. Now we're doing left 0-1 and 1-2 facet joints and no occipital nerve. So it really depends on the hands-on physical exam. Dan, hi, Christina. It's been a while since I've talked in these Facebook Lives, though. I've watched many of them afterward. I have multiple questions for you today. Thanks. Sure. Welcome back, Daniel. It's been advanced by DB. Have you ever seen a case of CCI from injury that improves over time with rest? Sure. You know, now realize that I've got a biased patient population, right? That patient population is reaching out to me because they're still having problems. And some imaging showed that they had CCI or suggested that they could have CCI. So I'm not seeing all of those patients that recover, but I actually just spoke to a patient this morning, telemedicine. The patient scheduled the telemedicine a couple months ago. While she was waiting to do that, she started doing some very specific type of exercises, was doing some other things, and she was feeling much, much better. So my recommendation to her was, we're not going to do anything. You continue doing what you're doing. Obviously, if you continue to get better and this becomes a non-issue, then you don't need me. And if it goes the other direction, I'm happy to re-engage. Or if you get to that point and it's plateaued out and you still have some disabling issue, then let me know as well. But more likely than not, I'm never going to see that patient outside of a telemedicine and giving her some advice on what to do. Dan, you talked about how approaching 1-2 facet sagittally. Not sure what you mean by sagittally. Helps to avoid the vertebral artery. Anatomically, is there anything similar that you do to avoid the vertebral artery of injecting 0-1 facet joint? Yeah, so Dan, in the 0-1 facet joint, the entry of the Centeno technique, the technique that I developed for 0-1 injection, which was an improvement on the old technique that I was taught way back when, comes in above where the vertebral artery lives. So if you adhere to that, you're above the vertebral artery. Now, obviously, we use digital subtraction, angiography, et cetera, to make sure we're not in there. But that's how that one works. Dan, can injecting the upper cervical facet joints overflow to any other stabilizing structures? Unlikely. Now, there are some patients that do have a portion of their alar ligament that goes and inserts into the 0-1 facet. So in those patients, we may be getting some coverage of maybe just the insertion of the alar. Now, It's more around that ligament than it is inside that ligament. So I don't know if it's going to help in the same way that as it would if we were injecting inside the ligament. AT, is there any new data or personal observations on prognosis of patient outcomes if diagnosed with CMS along with CCI? Is there a panic or compression? Does that need to be separately treated? I looked at this in what I called a home run analysis. It's probably 3 years ago or so, meaning that the theory at the time was that if the person had a pannus or cervical medullary syndrome, so that's where the dens is kind of touching the upper spinal cord and medulla, that patient would not fare as well. Regrettably, it didn't hold up. I found as many patients who had that, who did really well, as those who didn't. And there wasn't really any indication that having it made you more likely to fail. So at that point, I kind of abandoned that concept. Daniel, you said before that laser treatments are unable to penetrate bone to reach the alar and transverse. That being said, could class 4 laser treatments assist healing posterior ligaments or bulging discs? Well, probably not bulging discs, because you have the same problem with a bulging disc. You're not going to get to the disc bulge area because would be covered in bone, because it's in the anterior part of the spinal canal. And laser at the end of the day is just light. So if you shine a flashlight on a bone, you're obviously not going to get the flashlight to the other side of the bone, regardless of how powerful your flashlight is. But when it comes to posterior ligaments, supraspinous, interspinous, it's possible that could help. When it comes to some of the small tendons in that area, it's certainly possible that could help as well. Daniel, the Regenexx website says bulging discs are harder to heal than herniated discs. Why might this be the case? Not so sure. Well, harder to heal maybe is relative. So what they may be talking about there is the idea that a herniated disc is really just about ramping up repair while the body takes care of it, because the body will take care of it in most instances. A bulging disc is a little different, because bulging discs generally the body doesn't get rid of them like herniated discs. In fact, a good portion of bulging discs go in the direction of more bulge over time, because you get collapse of the disc height, and that causes more bulge. As far as so being harder to treat, if you want to treat a bulging disc, the only way we've seen that's worked is to use the hypoxic conditioned and culture expanded cells that we use down in Grand Cayman. So that's harder for sure. Daniel, injecting a spinal disc directly, if there is an infection, how likely is to destroy the disc? What kind of surgery would be needed? Can IV antibiotics administered immediately prevent damage? How long would it take to know if there's an infection? Yeah, I mean, the biggest single issue with injecting discs is, at the end of the day, what we call discitis. So discitis is a fancy term, pretty easy to parse out. Disc is for the disc. Itis means inflammation. There is inflammation in the disc, but discitis really means an infection in the disc. Now, we've learned in the last couple of years that discs have a microbiome. They've got their own bacteria that lives in there. So we used to think that we were somehow seeding bacteria into the disc, and we may still be doing that in some cases. But more likely what we're doing is upsetting the normal bacterial balance within the disc. And you've got one type of bacteria, usually a bacteria called P. acnes, having nothing to do with acne, that overgrows. And that causes an infection. How long does it take to detect that infection? It could be days to weeks, usually weeks, because it's rare that the person gets objectively systemically sick with high fevers. Normally what you see is dramatically increased pain that becomes unbearable. You get an MRI, let's say a week or two later. What it shows is that the bones are whited out with inflammation, the vertebral bones on either side, and that's pathognomonic for discitis. Usually get the patient IV antibiotics, the biggest problem being that getting a lot of IV antibiotics in the disc is not easy. So there's almost always, not always, but almost always a surgery involved as well to clean out the disc, which is obviously going to destroy the disc. How often does discitis occur with orthobiologic injections? I've heard people claim that everything from much less than 1 in 1,000 times to as high as 1 in 200 times. I use the number 1 in 300 times. Sometimes I'll use the number 1 in 200, but I think 1 in 300 is probably about right. And have that conversation with the patient. This is not likely to happen, but it could happen. 1 in 300 chance. This is what's going to happen if that occurs. As far as treatment is concerned, what do you want to do? And then the patient gets to make that decision. Robert, if there's partial calcification of the transverse or anterior ligaments, is there still potential healing ability with stem cells? Yeah, it's a good question, Robert. My personal opinion, and I don't have anything yet to back this up, but my personal opinion is if you've started to get calcification of the ligaments, it's not a great sign. Meaning that my sense would be that it could impact overall outcome. Now, I don't know that because we've not specifically done that analysis, but that's my personal belief. Now, it wouldn't be the first time my personal belief wasn't borne out by the existing data. So it could be that when we look at that, it doesn't really turn out that way, but that's my overall sense. It's been advanced by Gerald Stone. Hi, Centeno, you're scheduling now for when you return your next selling trip. So when will that be? I am out from September 15th to October 30th. So we are scheduling now for when I come back. I'm also doing 6 telemedicines a week while I'm gone to sort of make sure that I can get the most needy patients in. But this time we're actually screening those. So we're screening those to be the patients that we believe have the highest likelihood of being helped, so that we're trying to sort of make sure that those appointments go to those people where we really think we can create a home run. So that doesn't mean that if you don't get one of those slots, we can't help you. It just means that we're trying to prioritize that just to be fair to those patients who are much more likely to respond. Daniel, sitting in the car tends to flare up my upper back pain and my nausea much more than my neck and head pain. Is there any reason why this might be the case? There's certainly sympathetic nerves. There's the celiac plexus, for example, that go from the thoracic spine into the gut. So there may be some irritation at one of those levels of the sympathetic chain. One option would be to treat that level with a transforaminal epidural, maybe where there's a bulge, try to see if there's any lateral or anterior bulges or bone spurs that might be irritating the sympathetic chain, and then going ahead and doing a sympathetic block there at the same time to see if that helps the stomach issues. It's been advanced by Sherry Scott. If you have a setback and symptoms with CCI, does that necessarily mean CCI is getting worse in terms of measurements, or could it just be ligaments getting tired? If so, would rest help? Yeah, rest is a good idea for sure. Usually what's happened is not so much the ligaments are getting worse, but you're getting more and more nerve irritation over time, and then that summates and that gets to the point where it starts to cause a problem. So it's usually more nerve related than it is someone is actually having ligaments getting looser. AT upon physical exam, if there's noted instability in the shoulder or back, what is usually injected there during PICL? PRP or Prolo, maybe. So if there's instability in those spots and we can go ahead and treat that person, meaning that we can't treat everybody in multiple areas because some of our patients won't tolerate it, but most will, then we're doing a platelet growth factor enhanced prolotherapy. So that is what we call PL Prolo. So it's platelet lysate, 12.5% dextrose prolotherapy usually. Now, there are times where we're using higher dose PRP depending on the circumstances, but that's usually. Bo, are there any insurance companies that cover the PICL or any payment plans? As far as insurance companies go, Bo, we've got about 1,200 companies, not insurance companies, but companies that people work for that cover PICL. So the first thing to check is to see if you're employed by one of those 1,200 companies. As far as payment plans, we don't deal with payment plans on our end. Obviously, if the person wants to use a credit card and pay it off that way, that's fine, but we don't on our end. AT, what's the biggest mistake you've seen patients make during PSO recovery process? Something patients do that may hurt themselves that you've seen that can be corrected? Yeah, let's see. Probably the biggest thing I think I've seen is we've had a few patients, usually younger patients who have just gotten too crazy too quick. We don't really try to cordon off our patients' lives. We tell them that you want to listen to your body, but take it easy. If you can do this and then advance a little further, do a little more. If it's still not bothering you, do a little more, etc. So we've had some young patients. I can think of one college student in particular that just went crazy after the procedure, and it didn't work. And I suspect even he admits that, part of that was probably why it didn't work, though. There was just too much trauma. Now, obviously, many of my patients could never keep up with a college student in doing crazy things. And we all were there, right? We all did crazy things when we were younger, things we really don't do now. Especially as you get older, you start figuring out, hey, that could hurt me. I'm not going to do that. So that's probably the biggest thing I think I've seen. Strange. Hello, Dr. C. Do you normally inject both alar and transverse ligaments during the patient's first PICL? Usually we do. We'll get the transverse and the alar from below. In some patients that we believe can tolerate it, and where we don't have any doubt that they're going to tolerate the procedure, we'll also go above the atlas and get the upper portion of the alar. And that's maybe in a third of patients the first time. About 2/3, we just don't know how they're going to respond. So we stick with the more limited version. And then if they do well with that, then we do more the second time. Rhonda, hi, Dr. Centeno. My cone beam CT report says generalized features, inflammatory osseous changes, sclerosis, osteophyte. These findings congenital disease, osteoarthritis. This is a common finding in this demographic. Yeah, no, that would be expected for age, meaning that, we know there's a high percentage of the population as you get older that gets bone spurs in the upper neck and bone spurs in the lower neck as well. So I think that's what they're trying to say there. Robert, maybe mention that when one does X-ray inflection, when tensing muscles, it can hide the true ADI. Yeah, Robert, that's a very good point. So thank you for bringing that up. So we certainly have seen a few times that a patient who doesn't appear to have an increased ADI inflection will show an increased flexion or increased ADI during the procedure because we have them in a little flexion, and then we put them to sleep. All the muscles relax when we put them to sleep. So we've had a few patients now where it's they have a flexion view on something like a DMX, and it's a false negative because the muscle spasm is holding things together. And then we put them to sleep and boom, the ADI opens up. So that's a very good point to bring up. Andy, do you think progressive ankle instability or flat feet in hypermobile patients can lead to POTS? Maybe in someone can irritate nerves of the feet responsible for vasoconstriction. I think unlikely. John, is the enthesis where the majority of ligament strength comes from? Not really. Meaning the enthesis is where the ligament would attach to bone. So the enthesis is more like the anchor. So if we think for a second of Brooklyn Bridge, right? It's a suspension bridge, so it has those cables, but there are anchors on either side. Now, the anchors certainly provide strength, And the anchors need to be very robust because they're handling an immense load, the entire load on the cable in that case, or the entire load on the ligament. So they're stronger from that perspective, but really the strength of the ligament, or the strength to failure, would come from its weakest part, and the weakest part then would tend to be the ligament body itself. AT, how long before the procedure should we discontinue stem cell treatment formula and other anti-inflammatory supplements? So you can stay on the stem cell treatment formula. That's not a problem. We do ask that you get off of fish oil a week before the procedure. You can go right back on afterwards, but a week before the procedure, because that likely has, in most patients, a anticoagulation pro-bleeding type impact. Robert, how long after PRP can one take NSAIDs? Robert, I would give it a good solid month to be sure, 6 weeks to be very sure. We don't want any blocking of that normal inflammatory response. Now, most of the inflammatory response we're talking about is in that first week or two. But in some of our patients, it probably lasts a bit longer. So I think a month is a good solid bet. AT, what is considered an aggressive PICL treatment? Not so much aggressive, but more aggressive, meaning that the simplest one we can do is to go below the atlas. Then we can add above the atlas. Then we can add in things like the anterior longitudinal ligament at C2-3. We can add in the AAOL ligament up front, out to the side. So there's lots of different parts and pieces that can be added, and then obviously all the posterior ligaments. So you can take it from very, very low invasiveness, meaning very little, fewer pokes, to many, many more pokes. Tamara, if the C1 is sliding backwards and forwards, is this damage transverse, or could it be something else? Could have normal shape of C1 cause instability, meaning it's getting jammed at skull and subluxes. So usually if you're just talking about the atlas itself can slide against the skull, in which case we wouldn't be talking about a type 2A transverse ligament issue. We'd be talking about a type 1C, where that's what's happening, is the skull is sliding on the atlas. And normally the ligaments in the front that go from the skull to the atlas, and the ligaments in the back that go from the skull and the atlas are responsible for that. Eugenics been advanced by Fred. Would being anemic be a problem for treatment with PRP with you? I was turned down another clinic because I am anemic. It certainly could be, yes, depending on how anemic you are and how big you are. Meaning that anemia in a small patient is a real problem, because we can take less blood to begin with due to the patient's size. And then if you add anemia on top of that, we can take even less. So a lot of that would depend on your size and how severe the anemia is, but it could impact things. Finn, I keep trying to find out that interesting blog you wrote detailing ADI is increasing when a patient slept. Any idea the name of that blog? I don't know that it's a blog. I think it's actually a one of these Facebook Lives. So let's see here, Finn. Let's try to find that. Okay. So if we go to the YouTube channel, let's see here. That's me right there. Go to my channel. Then we'll go to find, and we'll type in ADI. See if that comes up. Yep, this is it right here. So false negative imaging of the ADI CCI 101. So that's the name of it. That's the URL up there. But I think if you just go to the channel and you type in ADI, it was the first one that came up. So that should help you find it. Let's see here. Andy, can posterior PRP and C0 through C2 joints cause worsening of POTS? Not that I have seen, no. But listen, fragile leg patients, anything can cause worsening. So if you're in that centrally sensitized fragile egg world, it's certainly possible. AT, how long after PICL generally should patients reintroduce themselves to curve correction and physical therapy to strengthen neck muscles? Not until you get approval from your doctor. That's one that we're hard and fast on. Nisa, is it possible for imaging like DMX to show ligament laxity, but it's actually the muscles pulling on the bones or ligaments, therefore it's not being ligament laxity or CCI, AAI? Not really, meaning that the ligaments are what determine the end range and what determine whether or not two parts and pieces can move a certain degree. The muscles provide mid-range stability, so they provide stability when the joint is in the middle of its range. But the ligaments are the only thing that allow separation of joint surfaces if they're damaged. So that one wouldn't make sense based on what we know. Mark, what's difficulty for injecting the first rib where it attaches the T1 transverse process? I think it's called the transverse costal facet or tubercle of the rib. Is this something most Regenexx providers could do? Fluoroscopy needed. Thank you very much. Probably not most Regenexx providers. A lot of Regenexx providers don't do thoracic spine work, just like a lot of interventional spine doctors don't do thoracic spine work. So I think that you are going to be hard pressed to find a Regenexx provider to do that unless they do a lot of thoracic spine injections. Now we do thoracic injections in Colorado all day, every day. So that's something we could do, but you would need to find a Regenexx provider who does a lot of thoracic work. And the reason why a lot of doctors don't mess with thoracic spine is the lung field is there. So puncturing the lung is a risk. Rishi, what does PRP or stem cells tighten ligaments, or how does it tighten ligaments in the neck? The same way that it helps tendons to heal, it just causes those cells to produce more collagen matrix and repopulate some of the dead cells when it comes to more of a stem cell procedure or a PRP procedure. It just increases the repair activity within the local cells. Nisa, does healing from PICL cause shifts in the muscles, ligaments, or bones, even in other areas of the body? My body feels like it's shifted. I'm feeling things in my ribs, in my back, which I have it before. That's certainly possible that, and especially if someone has scoliosis, realize that if you've got a side bend in the spine, your body has gotten very used to a certain position. And although the proprioception that comes from that position, so the proprioception or position sense of the upper cervical spine would determine how the body activates the muscles. So if you've got small changes there, it's going to change how those muscles are activated body-wide. Finn, theoretically, what would it mean if a patient CXA gets smaller in flexion but also gets smaller in extension? Not much. I mean, those CXA numbers are pretty darn normal. The only CXA number I really worry about is when we're getting in the 120 range, and that's when you start to see pathologic pulling pressure on the spinal cord there. Rishi, 2 questions. Are you able to say what percentage of patients you refer to surgery for CCI? And secondly, what is the ADI number where you make a decision first on a neurosurgeon? Is the ADI 5 or 6, for example? So the percentage of patients we refer to surgery depends on which point. So we see, probably 1 in 20 new telemedicines where things are severe enough where we're having them see a surgeon. And then eventually, since this procedure has about a 7 out of 10 success rate, we're recommending that those 3 out of 10, if they're still having disabling symptoms, so maybe that's 2 out of 10, pursue surgery or think about surgery. Now, a lot of them don't want it, so they don't get it. That's one of the reasons we're seeing them. As far as the ADI value, I've sent 5s and 6s off to neurosurgery and have not had them bite. You would think that they would, but they did not. So at this juncture, we just treat them because sending them to a neurosurgeon didn't end in a surgery. Finn, does LDN, low-dose naltrexone, affect PRP success? Probably doesn't affect PRP success, but as I've said, it certainly increases the risk involved in anesthesia. And it also makes the patient harder to put asleep. So just realize that if you're hard to put asleep and it's hard for us to keep you asleep, we may not be able to do all the structures we want to do because we're having to balance your protection against the procedure. So from that standpoint, it could impact success of the procedure. But intrinsically, I don't know of any properties of LDN that would impact PRP. Bo, success rate of PICL, is there anything that can be done to help with my nervous system and constant flight or fight in preparation for PICL, NUCA? So NAD injection or IV, no, that's going to be pretty worthless. NUCA could be very, very helpful, or AO. And success rate of PICL, as I said before, is about 7 in 10. As far as anything that can be done, I think NUCA or AO could be possible winners there. Sarah, if tolerated, is it helpful for patients to go off NSAIDs altogether moving forward? Do NSAIDs have any anti-healing properties? Yeah, NSAIDs aren't great for you. They dramatically increase your heart attack risk. We know that. Now, if you had to choose one NSAID that had the least cardiac risk, it would be a Aleve or naproxen. And as far as getting off of them or not getting off of them, I would tell all of my patients to try to replace their NSAIDs with things like fish oil, curcumin, glucosamine, chondroitin, and see if that allows you to get off of NSAIDs because you don't want that cardiac side effect. Now, if you have to be on NSAIDs, which are a contraindication for the procedure, but if you have to go back on them, naproxen would be the best bet because it would be the least toxic of all of them. Jeremy, is there any concern with DMX and radiation exposure? I've had 2, and I'm wondering if 3rd is worth it. See how much my cervical stability is improved or if another procedure is warranted. Yeah, so not really, just to give you a sense of it. A DMX is probably equivalent to a couple cross-country plane trips of radiation exposure. So kind of similar to, let's say, an airline pilot, maybe a month, let's say a month's worth of airline pilot radiation exposure. So if you're an airline pilot, you go high, you're going above the protective layers of the atmosphere, you're getting more radiation. Obviously, you and I may fly, a couple times a year, 5-6 times a year, whatever. But we're not obviously flying for a living. So I'm not concerned about those levels of radiation exposure. Nisa, is it normal to feel like they need to lay down more? Neck feels weaker, like you need to rest more several weeks post-PICL. So why might this happen? Well, it's certainly something that can happen if you're in that fragile egg central sensitization category, for sure. In general, after bone marrow aspirations, people can get fatigue. So it's possible that is leading to some fatigue. But if you're in that centrally sensitized fragile egg category, then obviously just the flare-up can cause that. AT, what's your opinion of dry needling the insertion sites of muscles that originate around C1, like levator and traps? Could this help to treat those ligaments or tightening post-procedure? Sounds like really you're talking about tendons, not ligaments. Tendon would be the portion of the muscle that attaches to the bone. And the biggest problem with needling there is we've seen at least one subdural hematoma from needling up in that area. So it's probably not a great idea to do aggressive dry needling in the high upper cervical spine without some sort of imaging guidance. And almost all trigger point dry needling would be done blind. So I would say probably not a good idea. Diana, is it helpful for you to have access to the imaging from an oral surgeon for TMJ? I have X-ray, open, close, MRI, the TMJ, open, close. Sure, yeah, we'll always take more imaging. Now, we may not request it because we don't think it's needed, but I will never turn down more than less imaging. Lissy, is the ADI between C1 and C2 joint? Yes, in the front. Mark, will Genetic Site give a list of those 1,200 companies that cover it? Yeah, I have been asking for that for a long time, for Genetics to publish all of that information. I think the problem is some of those companies would allow that, some of those companies would not. So best thing to do would be to get in touch with our folks, and then they can hand you off to Regenix. They can look it up on their end in the call center through the Regenix corporate program. But yeah, I've been screaming about that for years now, and it hasn't made a difference. Laura, hi, Dr. Centeno, what's typical prognosis of transverse ligament? PICL MRI report by Dr. Harshfield suggests transverse ligament is torn, adding that because it's the shortest ligament of the body, it tears all or none tear. Yeah, no, I mean, we don't use MRIs to look at transverse ligament injury, number one. So especially not low field open MRIs. We're really more concerned about the function of the transverse ligament. And that's why we would need something like a digital motion X-ray or a flexion extension upright MRI. If you had a complete tear in your transverse ligament, we would know it pretty quick because those two bones would become unsprung, the atlas and the dens. And when you went down into flexion, the dens would stick immediately into your spinal cord. So complete tears through and through and retracted back like a rubber band of the transverse ligament are theoretically possible, but almost never, ever seen even in a CCI population. So I think it's extremely unlikely that you have that happening. And if you did on your flexion MRI, we would see catastrophic things occurring. So I think you're probably not correctly characterizing what was said. Now, the problem for a reading radiologist and looking at just a picture of the ligament is the ligament picture may not look normal, but the ligament may still be functioning quite normally. And that's the issue there. That's the reason why we never use imaging alone, like an MRI picture of a ligament to say that that ligament is damaged or not, unless there's a clear retraction and there's no doubt. And then obviously even then we would follow it up with movement-based imaging to confirm. John, quick question. I know you hate towards facet capsule injections, but if a needle is touching the outside of the facet joint, lower sign guidance, aren't you on the capsule? I think you're talking about facet capsule injections as a term. So I think what we're trying to discuss here, and correct me if I'm wrong, is are you injecting inside the joint or not? Or are you injecting the capsule or not? As far as injecting the capsule, you can't see the capsule for the most part on ultrasound. So there's really no way to tell if you're in the capsule or not when it comes to cervical facet joints. If you're trying to determine if you're inside the joint, you also won't know that either. Now, sometimes you can see something that looks like it might be going in the joint, but we've seen too many times when we turn on the fluoroscopy machine and we inject some contrast, it's not actually in the joint. So again, it's just below standard of care for injecting cervical facets at this point. If your doctor is too cheap to buy a fluoroscopy machine and a vial of contrast, and obviously go through the training to learn how to do that, time to find a new doctor. Bo, I've been receiving neural therapy injecting tiny amounts of procaine the last 2 months for my relief. Sure, if you find it helpful, I would continue for sure. No reason not to. Vachin, is there a concept of tendon instability caused by tendons. How common would that be? There are certain tendons that can assist with joint stability. For instance, some of the peroneal tendons in the ankle, for example. But widespread tendon instability wouldn't be common. Hold on a second here. I always have to check my phone here. Okay, so just checking on some patient stuff there. Nisa, how do we support the collagen repair activity of the stem cell process? What if your collagen is somehow disabled? Is there anything to help support collagen repair in such a case? Nisa, we really don't understand that at a high level, meaning that we don't know if giving you collagen will help. I think the best thing you could do would be to control inflammation as best you can through diet. In addition to that, through taking all of those anti-inflammatory supplements while you heal. That seems to be the biggest issue that we notice. Sarah, this may be redundant. What is the specific cardiac impact of NSAIDs? Yeah, so they dramatically increase the risk for sudden death, stroke, and heart attack. What's the mechanism on that? It's believed to be that it increases the likelihood of arrhythmia, or that your heart rhythm will go dramatically unstable and abnormal. Of those, naproxen is the best. It increases that risk the least. So that just doubles the risk. If you were to use something like ibuprofen, now we're tripling the risk. If you use something like Celebrex, now we're quadrupling the risk. So that gives you some idea. So if you had to be on NSAIDs, the NSAID to be on would be naproxen or naproxen. Rishi, how long do you recommend an international patient stay in Colorado post-PICL or post-posterior injections? If it's PICL, definitely a whole work week. If it is posterior, then you can cut that down to 2 or 3 days. Darren, I've heard of a procedure called chondro filler. What do you think of it? I have not, Darian, but there's all sorts of new crazy stuff every day. So let's look up chondro filler. So it looks like this is a Europe-only thing. So it looks like it would be the equivalent of a type of collagen filler used in the face in the U.S. And might it help joints? I would think that it would act an awful lot like a Synvisc or hyaluronic acid injection. And guys, I do have a 2 o'clock meeting, so I've got only 6 minutes left. So I'm going to try to skip around a little bit and get questions that are kind of new here. Quick question, Dr. C. When you're talking about calcified ligaments, is something serious? Also including the stylohyoid ligaments? No, not talking about that. Daniel, are we sharing research, other doctors, chiropractors? Yep, I've lectured this year, I think 3 or 4 times, somewhere in there, to doctors, chiropractors about PICL. Can thoracic hyperkyphosis cause neck pain similar to cervical instability? It certainly can. Let's see, I'm just going to skip around here because I'm at my last 5 minutes here. Liam had actually 8 weeks out from PICL2 and doing very well, feeling significant improvement last couple of weeks. I started doing CCI laser exercises and wondering how fast should I progress. Yeah, so really you just take very slowly and progress through those. And when you start experiencing a symptom flare, you back off and then just let us know where you were able to get to. But great to hear it, Liam. B12 injections, well, I don't think it'll help this, but certainly could help other things. Is there significant evidence to prove that PRP is a disease-modifying agent now? I think we're getting there, further along than we were 2 years ago. So I'd say that I'd bet a reasonable amount of money that it is to some degree, but I wouldn't bet the farm yet. AT, what is the average length of time post-injury for patients getting treatment in general? How long would you assume until there's a real chance ongoing neurologic can become baked in? Oh, I think that's different for everyone, and it depends on so many different variables, everything from genetics to systemic inflammation to how much damage is occurring, et cetera. In general, we like to look at, there's a difference between someone we're seeing within that first year. We can usually do a single procedure and then they're done, versus someone a couple years out, they're going to need, in general, 2 to 4. Versus someone who's 20 years out, where the neurologic damage is likely baked in. Liam, do you have any suggestions for how to improve excessive thoracic kyphosis? Yeah, I think the biggest suggestion is certainly working with a physical therapist. They've got to open up the chest. There's some conscious effort as well not to do these sorts of things. There's some daily stretching that has to be done, all that kind of stuff. Nisa, okay, thank you. I will try to do an anti-inflammatory diet and continue to take regenerative form. I was hoping fatigue and collagen synthesis. What is the next topic on Monday? Ulysses, I don't know yet, but I was thinking of trying to do some of these that are more case study based. I've had so many interesting cases lately that I might just do with the patient's permission, but not use their name, do a specific case, show you their images, talk about what they experience, and then, specifically how we would treat that. So you guys can let me know if that sounds good or not. AT, can light exercise like recumbent bicycle help post-PICL? It can, as long as you don't aggravate your symptoms by doing that. Okay, guys, I am going to have to start wrapping this one up because I've got a 2:00 meeting I need to get to. Appreciate everyone's great questions here. MRI with CCJ. Yeah, so again, it doesn't really make a difference, meaning that we don't use MRI to call ligament damage at all anymore. It has to be a functional study, meaning a functional study is one with movement. Okay, guys, so appreciate everyone's questions. Again, there's no bad questions here. We learn through questions. And I want everyone to have a fantastic weekend. Not quite sure what the topic will be on Monday, but we'll have a good one. And I'll see you on Monday. So have a great weekend. I'm going to get going to my meeting. Thank you.